Good afternoon and welcome to this week's Tuesday Tea. I'm here to introduce some very special clinicians who are going to be talking about neurodiversity affirming care in the perinatal period. So I'm pleased to I'm pleased to introduce Erin Wheeler, who is an LCSW PMH-C. She is a neurodivergent therapist, parent, and private practice owner based in Chicago. In her therapy practice, Erin specializes in using EMDR to assist perinatal clients in healing from birth-related trauma and helping neurodivergent clients navigate the profound transition into parenthood. She's passionate about shared learning and the advancement of perinatal mental health in the broader trauma therapist community. Erin recently became an embryo-approved consultant in training. Congratulations. Her lived experience as a neurodivergent parent has also helped her see openings that still exist for greater understanding of neurodiversity and neuroaffirming care within the perinatal therapist community. Jane Kosloff is an LICSW PMH-C and a neurodivergent therapist in private practice in the Seattle area. She is a consultant in training and an approved clinical supervisor. Her areas of clinical interest include perinatal trauma, anxiety, perinatal OCD, and supporting neurodivergent clients. Whether it's teaching, consulting, or mentoring, Jane feels at home working with fellow clinicians. Skylar Ibarra LCSW PMH-C is a therapist in private practice and EMDR consultant in training from Southern California. She specializes in neurodivergency, perinatal mental health, OCD, and trauma with a special interest in how those four experiences overlap and express within her clients. Skylar utilizes her extensive clinical experience as well as her lived experience as neurodivergent and having OCD to inform her conceptualization as she works with both clients and in consultation with other clinicians. So I'll let them take it away. I know that they're all very excited to inform us in this Tuesday Tea. And a little later today, they'll be sharing with us about their upcoming training.
Thank you so much. I think we're ready for the first slide.
All right, good morning. We're excited to talk today about neurodivergent affirming care in the perinatal period. So we wanted to start by talking about language a little bit, that the language we use matters. The autistic community is clear that identity first language is the preferred default. So you're going to hear us, saying like autistic instead of person with autism. And ADHDers are adopting the same language. But there's some important notes here that not everybody will personally identify with this language. And while this is the default, at this moment in history, it's still up to the individual to determine what language they want to use to describe themselves. So we're going with what the general community uses and feels comfortable with, but it's always going to matter more what the individual is wanting to go with. And we wanted to note that language of oppressed groups will constantly change. It's not static, so this is where we are now, but that is likely to continue to change. But we just wanted to note that when you hear us say ADHD or autistic, that's a choice. There's a reason that we're using that language here today.
Yeah, so today we're going to be talking about neuroaffirming practices in the perinatal period. And when we do that, I think one of the things that you'll notice throughout our discussion are some core pillars, some core principles that make up this affirming practice. So we're not going to go into each of these today. It's something that we're really going to deep dive into in our training, which is exciting, and to see them kind of show up in your cases and case conceptualizations. But today I'll just kind of reference them as a starting point, and hopefully you'll hear them woven into some of the answers that we'll give. So the big things that we see in affirming practice are intersectionality, right? Understanding and respecting autonomy, which is huge, autonomy and choice, and validating differences. So not seeing our group, our neurodivergent clients as a monolith. Pursuing competence, which is such a nice shift in perspective, assuming that there's an expertise that our clients and resources that they bring in that we're not having to impart on them. Reframing expectations both with the client and of ourselves. Promoting self-advocacy, which sometimes includes clients, being mad at us and embracing that. Rejecting neuronormativity and understanding how neuronormativity shows up in our own expectations and work with our clients. Prioritizing lived experience. That one we'll really deep dive into, and how important it is to understand that the models we have for even defining neurodivergence are social constructed, that are based on white supremacy, and lived experience is not just valid, but is more true than what we're going to be getting from the DSM. Nurturing positive self-identity and understanding that identity formation is actually sometimes more important than label. And then adapting systems and environments. We're thinking about, even within our therapy office, the ways in which environment plays a role in supporting our clients. And then honoring all forms of communication. And that's really important in terms of sort of depathologizing and destigmatizing ways in which communication doesn't feel familiar or comfortable to us. So again, we'll get more into some of these, but that's just a brief overview.
So we're going to spend a little time with each of us talking about how neurodiversity affirming practices and care have impacted how we work. And so I have two examples here, and I'm going to give some more specific examples after this, that being able to engage and build relationships with neurodivergent clients more authentically, and collaboration and being flexible around structure of sessions. So for the first one, the example that has come to mind for me is around that a lot of neurodivergent people have a lot of really deep interests and passions. And earlier in my practice, before I knew as much about ADHD and autism and neurodivergent affirming practices, I would see, like, when somebody would talk about interests of theirs and you could just see them really light up. And I always really enjoyed that and wanted to spend a little time there. Like, it felt right. But there'd be another side of me that would worry about, oh, is this clinical enough? Like, am I using their session time correctly? Am I doing a disservice to give time to talk about something that isn't, that I wasn't taught as something that we should be spending time on in sessions? But after learning more, really have, come to understand that instinct was right the first time, that being able to connect with people around their interests is really important. It's, I think, also seeing people more holistically, right? Like, what somebody's interested in is important to know about. It's also fun for me. I like getting to see people light up, and usually I get to learn some new things. And I do think it's a way to really build strong relationships, to show that you are interested in and care about what they are interested in as well. So it's been a nice shift to kind of have permission that, yeah, this actually is something that is helpful and really important, actually. And then the second one here, the collaboration and flexibility around structure. Like, the example that comes to mind for me there is around ADHD clients that say I'm, it's an initial session with somebody, and just see that they have a tendency that there's someone who's more talkative, and we ask a question, there'll be a longer answer. And there's absolutely nothing wrong with that. But I am going to want to think about what structure of the session is going to feel best to them, but not just on my perspective, like to work together with them on that. And what that might look like is, one, me asking a little bit about their experience in therapy before, if they have that experience. And oftentimes I'll hear something like, oh, I would often feel kind of lost. Like I'd be answering questions, and then before I knew it, the session would be over, and I don't really know what I talked about, and like I didn't really get to talk about what I wanted to. So when that's the case, I'll ask the client, like, how would you feel about the idea of me interrupting sometimes, with explaining why I would interrupt? I'd say, explain it's never about being uninterested in what you're saying. It's not about anything being boring or anything like that. Like, why I'm asking is like, would it feel better if we come in that day and say, hey, like this seems important to talk about, but I realize we've been talking about this other thing for a while, that I'm going to check in and like, hey, like, is this feeling like where we want to be today? Is this feeling useful? Is this feeling helpful? And if it is, great, we'll go with that. But if it's like, oh no, I actually really want to talk about this, then we'll go back. And I have found a lot of clients find that really helpful. But again, I think a key part of it is being collaborative around it. I also don't want to assume, just because somebody tends to be more talkative, that being interrupted would feel good. So I'm going to want to ask. And I find that it just can lead the sessions to feeling better when there's a lot of conversation around what's going to feel best, adding structure when needed, or maybe a little less when that doesn't feel good.
So for me, when I fully embrace neurodivergence affirming care, neurodiversity affirming care, I stopped feeling like an imposter for the first time in my career. I hear imposter syndrome all the time, and it's because we're really molded into therapists in a medical model that we hold the keys to diagnosis, we hold the keys to treatment planning, that so much responsibility is on our shoulders. And even though that never felt right to me, it actually created a lot of anxiety for me within the therapeutic space. I didn't really know that there was an alternative. And so when I really embrace non-hierarchical care, when I realized that it's collaborative and that my client truly is the expert of their own lives, I was able to no longer worry if I had the answers, because I knew for sure I didn't. I knew that I was here to hold space and to allow my clients to recognize what they needed for themselves, really bringing in that self-advocacy and that autonomy. I tell all my clients now that I'm the navigator of the ship, but they're the captain. So I may know the routes and I may know the path, the different passageways we can use, but they are the one who knows the ship, who knows the crew, and knows what the full scope of the mission is. And so in allowing all of us to really shine in our expertise, but working together to allow for that healing, it's transformed who I am in the therapeutic space, and it's really transformed how my clients process within our therapeutic space. And it's just been a really beautiful thing. And then also just breaking free of the rigidity of what it means to be professional, and also what it means, what I expect from my clients. I think there's a lot of people, especially when we all went into lockdown and telehealth was new. And then there was these people going, I don't allow my clients to eat during session, or I don't allow for this, that, and the other. They need to get out of bed. And I'm like, why? Right? I would rather have my clients show up authentically, take care of their bodies, take care of their stems, do what they need to do to be able to be fully present, instead of trying to mask what respect looks like for me, because they don't need to respect me. We need to be able to work together. And I think those are two very different things that can be confused really easily, especially within a hierarchical lens. And then also just, what does it mean for me to be a professional? I am very clearly neurodivergent, right? Like, that's just who I am. I know that if I need to make sure if there's a calendar change that my client's still on video with me, or, still in the room as I changed it on my calendar, or all chaos will break loose. Like, there are just things about me that are neurodivergent, and they're seen as not professional. But the thing is I'm able now to model that this is just who I am, and it doesn't impact my abilities or my professionalism to be able to also accommodate for my needs. And being able to be just a human being with another human being has, again, allowed me to have this comfort in the therapeutic room, that means that I get to spend the time really being there for my clients instead of trying to project what I think I should be to people. So it's been revolutionary.
Yeah, I just really quickly want to piggyback off what Skylar said. I have my awesome squishy ball here and my emotional support tee. So those things are, yes.
My origami.
Yes, Skylar does paper folding, right? Like, and Jane does crocheting, which she's created some amazing little animals and figurines. So we've all been excited to share that with each other, but that also shows up in the therapy space with our clients. And it's, I think for all of us, I'll speak because I think they've expressed this, that's such a relief as a neurodivergent clinician as well. But I hope that even neurotypical clinicians will feel a sense of freedom in being able to meet their own sensory needs as a modeling of that openness for their clients. But in thinking about the impact that neuroaffirming practice has had on me, I think helping clients reframe some behaviors that they would see as odd or weird, or they just don't understand why they do it, and there's some shame around it, and being able to be curious around that and notice and name why that's actually an act of caring for themselves. So, for example, a client of mine who is alexithymic, so having trouble with sometimes being able to access, the signals of emotions and feel that and identify that. So oftentimes it's either, kind of all or nothing feeling, and being able to provide some feedback around ways in which sometimes folks who are alexithymic can use other methods to connect with emotions, like listening to music or watching the movie that makes them feel, makes you feel sad, and then being able to access that emotion. And seeing a client recently go, oh my gosh, that's why these breakup playlists have been like, I never put that together, and with a lot of our neurodivergent clients, like being able to name that why is so important to making sense of it. But just to be able to see that and honor that idea that the wisdom is so oftentimes so already there, but it's the ableism that has, convinced clients that what they're doing is not right or good, or is basically wrong. So anyway, the other thing that I think has been profound for me is changing my relationship with experiencing different levels of intensity from clients. So feeling more comfortable with, higher levels or lower levels, without viewing it as an indicator of pathology. And this may get me into a little trouble, but I think trauma therapy has its own sort of version sometimes of this, where when we experience higher levels of emotion from clients, we kind of can automatically go towards maybe a reenactment or triggering of past trauma. And, lower levels, we tend to go to dissociation. So assuming that there's some trauma-related trigger, and then those become the targets of treatment. So, the relational reenactment, what is the trauma triggering? What is the dissociation? And that's not to say that can't be present, but sometimes there's more. And sometimes it's not a reflection of something that's getting in the way of growth. It can be part of just the way in which someone's naturally experiencing their emotions as an aspect of who they are. So making space for that has felt incredibly important.
So I think, Taina, if you want to jump into.
Sorry, Mike. Thank you for that. So I'm wondering if I can just ask a couple of questions. How, when clients are showing up in your space, how are, as clinicians, are you making that differentiation between autism, ADHD, trauma, complex trauma, and how you're making determinations?
I think instead of determinations, for me, I come from a place of curiosity, right? And allowing for my client to utilize their own tools to be able to make those recognitions for themselves. Because so often they overlap and they intersect so much that to try to untangle everything all at once is really not even it's kind of a thought experiment versus a therapeutic process. And so for me, what I see, especially in my phase 2 work, is building up the skills for that own filtering and determination, right? What does it mean to allow for curiosity? Usually there is a lot of breaking down of ableism, right? So if there wasn't this expectation that you would perform a certain way, would you still do this? And then once we're able to kind of allow for that, allow for more interoception and allow for more self-compassion, then we can start to go, oh, no, this actually feels compulsive, but actually it's I'm just meeting a sensory need. Or, I thought that this was 100% because of my trauma, but really what happens is that when I'm activated, my sensory needs become much more pronounced. And so this part of it is just because I don't need to target my self-soothing, I need to target the trauma itself. And so we kind of, that whole peeling the onion, there's a lot more layers of the onion when we're working with neurodivergency, because one of my things that I hear all the time is like, oh, they're neurodivergent, but no other trauma. There's no trauma there. And it's like, well, being in an ableist world is inherently traumatic. And so being able to, and I think a lot of the neurodivergent experience, especially for ADHDers, for autistic folks, for those with dyslexia, right? So much of the pathologized treatment construct is around the trauma reaction to these, not to the inherent experience. So much more complicated answer, and I'm sure Shane and Erin have more, but it is at the end of the day, again, that non-hierarchical care and allowing that I'm not making the determination, my client is.
And yeah, I think with that curiosity, it's really wanting to hear what are the client's thoughts on this? Like, as far as like ADHD and autism, is that something they have thought about? Because there's plenty of folks where I'll bring it up. I'd be like, hey, like, there's some experiences that you've mentioned that can match, some experience of ADHDers. Is that something that, you've thought about or before? And it's not uncommon that I'll receive a response that's like, yeah, I've thought about it a lot, but I don't think that can be true for me because of X, Y, and Z. And usually those reasons are not, and that is a really good just starting point to have these conversations. Like, and I also just really want to say, like with what Skylar was saying, that for a lot of people, the self-exploration is a long process, that teasing this out is not just a simple question. And I think with the neurodiversity affirming stance, there's less pressure, I think, for the therapist just to have to figure it all out. That's not necessarily the expectation.
And just to piggyback on that, I want to really honor the roots of the neuroaffirming movement within the queer theory and trans rights movement, and the background of gender affirming care and the shifting the perspective of the role of the provider, of not being the determiner of someone's like enoughness within these categories. And so we don't say like, oh, well, you're telling me that you're exploring like gender, your gender expensive identity, but like, I need you to meet these qualifications in order for me to be able to sit with you in that and validate your lived experience. And so that I really hold on to and take from the work that's been done by the queer community, to be able to hold like that appreciation for that perspective, because I think it's so incredibly important in what we're trying to do for our neurodivergent clients, and really just with anyone who's subject to ableist labels.
Well, and I think that that really goes with the shift from diagnosis to identity, right? I'm never going to diagnose anybody with being gay, right? Like that would be so inappropriate and nothing within my purview. But 40 years ago, it was in the DSM, right? So as we grow, as we understand lived experiences, we can depathologize. And I think it is really hard because there are disabilities associated with ADHD, autism, dyslexia, because our world is not set up for those lived experiences. And because so many services are locked behind these official diagnoses, it is still complicated. But just because it's complicated doesn't mean we don't go there. It doesn't mean that we don't have these conversations. And I think that neurodiversity affirming care, first and foremost, really embraces the complicated lived experience within this ableist society. And we discuss it and we name it and we allow for the identity to persist regardless.
Thank you for that feedback. I have a question about clients who, as you're in the EMDR process, have difficulty with visualization. What types of workarounds do you use for those types of clients?
So as somebody who has aphantasia, I will, so I didn't know I had it until I was like, yeah, I can totally see things in my brain, but it's like these flashes and very black and white kind of fuzzy things. And when I actually saw if you Google it online, you can see kind of this spectrum. And I was like, oh, I barely see the apple. And so I feel that what works for one person won't work for the other. So this is, again, curiosity. But I was trained before EMDR. I was trained in somatic modalities. And so connecting to the somatic, allowing for that interoception, the implicit memory for most people is going to be stronger than the explicit memory anyway. And so being able to target the felt sense of the experience is going to be powerful for just about everyone. Again, there's no always, but for most people, strengthening that connection and working with the somatic impression of the worst part of that experience will be just as powerful as the visual one. For other folks, they need external visualized cues, right? So let's bring up a picture of your safe, calm place. Let's look at, let's draw, let's sculpt. Let's use what you connect with most and you can experience in your body most and go from there. There doesn't have to, I think that because Francine Shapiro was clearly a very visual thinker, all of EMDR was created on what worked best for her. And then that was then generalized to other people. I had a yoga instructor once when I asked, because my body moves very differently from other people's. And I was like, I can't do yoga right. And she said, there is no doing yoga right. There's doing yoga correct for you. And if anybody says there's a right way, it was because it was the right way for them. And it may have aligned what was right for their teacher as well. That's luck. That isn't, needed skill. And I take that so much within my practice as well. What works for me may not work for my client. And that doesn't mean that we're leaving protocol. It means that we're adapting protocol to be appropriate for each one of the people that we're working with in our room.
And just to add on to that, I mean, one of the things that I'm really excited to get to even more depth around in our training is that, like with EMDR, when we look at the different pieces, like with phase 2, or phase 3, with resourcing, like what is the goal, right? And I think for everybody, we're taught, like as Skylar was saying, like a lot of visualizations, right? With complex and container usually is taught visually as well. But if we look at what the goals of them are, the goal is not around having a perfect visual image, right? It's being able to tap into these inner resources of grounding or calm or whatever people are needing. And visualizing is not, you know, as the examples that Skylar was giving, are not the only way to get there. And when you really look at it, it doesn't seem like that was really the goal. Again, it's not to build this amazing visualization, right? So looking underneath it at what the goal actually is can then bring in a lot of flexibility that, as Skylar was saying, is still completely within protocol. It's just being able to modify it to make it just work well for whoever we're working with.
And I think that that really goes into something that the three of us have been talking about a lot. And I know that I talk with my consultees a lot about is knowing what is the purpose of phase 2. Because I think so many people see phase 2 as a checklist. Have I done light stream? Have I done calm, safe place? And have I done container? If I've done that, done, let's move on, right? It's seen as almost this like very cursory check mark. But if we really look at the purpose of it, it is to be able to regulate the nervous system and allow for people to switch from a distress place and back into their window of tolerance. And so that may look differently in neurodivergent folks, right? What one person can shift, you know, easily down, for another person, it will require a ton of sensory input. It will require more time, more breaks. That doesn't mean that they're not appropriate for EMDR. It means that we need to spend time in resourcing to make sure that they have the tools to be able to take care of their own body and their own nervous system.
This is where, I mean, also, I think this is like for working with both like across the neurodiversity spectrum of neurotypical and neurodivergent clients, being able to strengthen the understanding around the AIP model and the importance of really being curious about the diversity of processing and sensory and within the assessment and the resourcing phases is so important, because regardless, that's going to set us up for what type of interweaves are we going to use, right? How are we going to engage in a SUD scale, right? So all of that, you know, we sometimes are going through the motions of the first couple phases and thinking we'll figure out some more later on. But how important that first couple phases is in just setting our, like, building that awareness of our client, for our clients and for us, of what's probably going to be the most helpful and why, understanding the why, so we can just be flexible and attuned also to our intuition about what they may be needing. So we're excited in the training to help, you know, clinicians start to feel that confidence that they can see the why and then be able to bring in a lot of creativity around that too.
And just to highlight, I just really loved how you mentioned, Erin, that I do really think that this sort of viewpoint and being able to look at EMDR this way, it benefits every client, whether, you know, they identify as neurodivergent or not, because there are, you know, we have different needs, right? And being able to see what someone's needs are and have these different ways of thinking about it, or not kind of assuming everybody needs a certain thing or not, is going to benefit everybody.
And understanding, I think when we know the why and the purpose of something, it frees us to then make informed choices instead of having to adhere to exactly what we were taught. Because I see so many people, I mean, at this point, I've had the honor to work with people that have gone through, I want to say 5-6 different EMDR trainings, and they're all going to be slightly different. And if they can't explain why they're doing what they're doing, then they become very attached to, I have to do it, instead of this is a choice point. And so being able to then look at AIP, look at standard protocol and really finding where is my wiggle room where I'm still doing good EMDR outside of what my training manual says, but training manual is not all EMDR. It is opinions.
Can you talk to people who are in the postpartum period who are identifying maybe with ADHD, but have symptoms that can overlap with postpartum depression and anxiety?
Yeah, I mean, I think that this is, all of us are consultants, and it's certainly something that I think we hear a lot from clinicians who are, noticing some anxiety about, having more and more postpartum perinatal clients coming and self-identifying or expressing curiosity around their neurodivergence, or whether or not they're neurodivergent. And the clinician sort of wondering like, okay, well, how do I handle this? And what's, is it this or is it that? And one of the things that I really try and do is sort of bring curiosity even to the clinician experience there, and sort of notice this pressure and this assumption that often arises between this sort of logical disqualification. Is it this or is it this? Mm-hmm. You see this around discourses of perinatal anxiety and depression versus ADHD autism. You see this around trauma and neurodivergence. This sense of, well, is it trauma or is it neurodivergence, right? Is it perinatal anxiety and depression, or is it, neurodivergence? And this sense of responsibility to try and like figure this out, both for yourself and for the client. And I just want to give permission to release that responsibility, and to also emphasize that so often, again, taking that multiplicity view of the neurodiversity experience, and that it's going to more often than not be all of yes and yes and yes. So really holding that's an equal possibility, that it could be either or, but it's actually probably more likely it's both. And to engage in looking at that together. And I think to piggyback off metaphors with clients, one of the ones that I've really loved is talking about, going into a dark house, like an abandoned house together. It was kind of scary. We don't know what it's going to look like. And, my role is not to know everything in the house, and to be able to tell you where to go and how to prevent yourself from hurting yourself, and tell you it's going to be fine. I know you're going to be able to get through it. It's to be, walking side by side with you, maybe arm in arm, and holding the flashlight and saying, do you want me to shine it over here? Or do you want me to shine it over here? Should we look at that or should we look at that? Could that be a cat, or is that, like a stool? What is that? That's the stance that we're really trying to embrace when clients are showing and saying, let's shine a flashlight on this. Okay, great. I'm here. I'm the one holding the flashlight. Let's do this, So I just want to offer that as a shift. And if that feels, and it's familiar to me, that anxiety that I felt in the past to decide.
I think another element that comes to mind for me is, I think this goes along with everything you were saying, Erin, but just looking at outside of the identities that somebody's identifying with or not, or questioning or not, or the therapist is questioning or not, just what is the experience? Because whether we know their identity, the client is settled on their identity or not, if somebody is experiencing a lot of struggle with sound, right? Like maybe the baby crying, there's things that we can do to help support them, without a neurodivergent identity attached. Same with like executive functioning differences, like memory or tracking things. Like we can help and we don't have to know, right? So sometimes even stepping back from that can give us room to to help right in that moment. Because if we look at just what's going on with somebody, right, and what they're asking for, what they're needing, what's difficult, knowing the exact identity is not necessarily the key to being able to offer them support in that exact moment.
Well, and I think also we need to explore ableism through all of this as well. And I so often get feedback from other clinicians that when they hear a client say, I think I might be ADHD, they immediately go to stimulant seeking, right? Oh, well, if you're ADHD, it's just because you want the easy way out with a stimulant. And like, I'm sorry, ADHD is never going to be the easy way out, just point blank, but also just the assumptions that come from that. Likewise, I hear with a lot of clients who are, seeing it like, are they autistic, and going through that identity questioning, I hear so many clinicians go, oh, they just want the easy way out. They just don't want to take responsibility. Well, guess what? I have never worked with an autistic client who doesn't take way more responsibility than they need to. And it's really stepping back from that masking and allowing for like, no, like you are in a system that was not created for you and are struggling because of that. And when we again allow for the lived experience identity model instead of the pathology and diagnosis model, it fundamentally changes how we show up for our clients and how we validate and affirm our clients. So allowing for curiosity is not somehow, allowing somebody off the hook. That's really just, if we think about it and sit with that, I hope that doesn't sit well with anyone. And exploring why we were primed as clinicians to think that way in the first place.
And just to add to that, and this is the way our conversations work, by the way, just, we're just adding to each other's thoughts. We could do this for hours, which we do this for hours. But I think that one of the things with the masking that I think is important is that we, oh my gosh, my brain is doing the thing that it does. The bird flew out the window. Oh man.
It's almost like you're neurodivergent or something.
It's almost, yeah. Oh no, but I think that one of the particular challenges with the perinatal period, that just to piggyback and go back to what Jane was saying with sensory tools supporting all perinatal folks, and that's something that we can integrate regardless of identifying. Mm-hmm. And I think that it is challenging because the perinatal period is so overstimulating. It is so intense, right? There is so much sensory stuff. There's so much relational communication stuff. There's so much intersectional trauma there that masking is part of it, regardless of whether or not it's from neurodiversity or your race or your class or gender, all these things. So it gets really complicated. But I think the hard part too is that sometimes clinicians, when they recognize that this isn't a difficult period and it's more difficult, there can be a kind of and I don't want to say this, if you've ever said this, don't feel bad, but like there can be a sense of a sort of condescending care where it's like, you just need to be less hard on yourself. Like, this is a hard time for everybody. The perinatal period is really overstimulating. It's overwhelming. You're not alone. And for someone who's been masking all of their lives and they're trying to finally say like my coping strategies have exceeded the demands of this period, and I am crashing in the weight of that, to hear that, which is meant as a supportive reflection, can feel so isolating and trigger so much shame. So it is a complicated thing. And
Well, and also pointing out, during the perinatal period, we are in just hormonal tidal wave all the time. And when we look at diagnostic criteria, they were looking at mostly middle-class white boys who, shockingly, probably were not menstruating. And so when we look at those of us with menses who have, especially, ADHD, it's not going to be this flat line throughout our experiences. We're going to have hills and valleys, much more so tied to our hormonal shifts. And so not only are we dealing with the identity experience, with the sensory overwhelm, with, every structure that we put in, every system we put in place just completely decimated from this, little wriggling life that we love and is also very overwhelming. But we're also experiencing our ADHD in a completely different way. And so ways that before it kind of slipped through the cracks and we just accepted it as normal, for the first time we can say, oh, wow, this is not normal. This is harder than other people. And it's okay for some people for it to be harder than others. And our role as clinicians, to exactly piggyback off of Jane, what you were saying, sorry, not Jane, Erin, what you were saying is that by being able to go, wow, this is really hard for you, we're not making it harder. We're instead holding space for the lived experience. And that can be transformational.
On that note, can you tell us a bit more about the training that y'all will be providing for Touchstone?
So we are so excited to be able to really pool all that all of our passions and all of our hyper focus into this training. When we first started, we realized, okay, we know that we have, probably 5 weeks of training between all of us, but definitely 2 full days where it's more of a general overview of what's going on in the perinatal period. But as EMDR consultants in training, we also recognize there are so many aspects of neurodivergency and EMDR that are just not being explored right now in depth. Or, we have some colleagues who are really starting this as well, but especially not in the perinatal period. And so we're really bringing together all of our interests and all of our passions into this 3-day training, where that last day is going to be the optional EMDR intensive, looking at how do we weave, and we're sprinkling EMDR throughout, but how do we now weave together the last 2 days of neurodiversity, affirming care, of perinatal care, and how do we really sit with our clients and provide this effective EMDR interventions that, instead of pathologize, which we unfortunately see time and time again, people who don't understand neurodiversity are targeting traits instead of targeting traumas. And how do we start to step people back from that and really recognize how we can be affirming, effective clinicians with our clients?
And one part that we've talked a lot about is that we are making this training accessible both for folks who are new to neurodiversity, maybe in general, and neurodiversity affirming work, and for folks who maybe have been deep diving into this for a while, that we're finding a balance of both, that there's going to be some new information or new perspectives, but also if this is brand new, if this is still, I think that there's still a ton to get out of the training.
Mm-hmm.
And just to piggyback that, we're really excited for this training to help to provide a lot of opportunities for somatic engagement, case conceptualization, shared learning. So this is going to be a really engaged and hopefully embodied, as much as feels safe to whoever's there, experience. And we actually, we're so excited to have Dorit Halpern, who's a fellow CIT and neurodivergent parent from Israel, to come help with some of the somatic kind of parts and being able to look within our own identity and clinical practice as well, and start to connect with what's showing up for us and how we feel embodied in that relational dynamic with our neurodivergent clients. So we're so excited to have them join us and to be able to really feel and dive into some of these concepts.
Because I think
was just going to say I'm so looking forward to this training, and I know that many of the people who are in the Touchstone space have really been waiting for a training like this. So I thank all of you for just sharing your expertise. And how can people sign up for the training? Mindy has shared with us the link here, and we had many people just kind of join us in the comment section. I hope that you saw that everybody was saying that they are hungry for this knowledge, and that they want to watch this again. And for those people who could not join for the entire time, there are people who have bookmarked this to watch it later this evening. And we're just really looking forward to sharing that with the community. So thank you all so much.
Thank you. Thank you for the opportunity. We just can't wait to see people there, and then also know that we've created a community here that's growing, and so we hope that just like Mara's been able to create this wonderful, powerful perinatal mental health community, we're piggybacking off of that energy and really trying to build that around the perinatal neurodivergent community. And so we welcome you in whatever ways that you feel you want to join us, whether or not it's being in the training or not. So we're very excited.
And just as a reminder with the training, there's a 2-day option and a 3-day option, where the 3-day option is that 3rd day is where we'll really dive deep into the EMDR component.
Amazing options. Thank you for joining us again for Tuesday Tea. We'll see you in a couple of weeks.